Risk factor-based screening for hepatitis C has failed to identify the majority of patients. At least 75% of patients are currently unidentified using the traditional risk factor-based screening. And this is because the risk factors are generally many years in the past. So patients either don't perceive them as risk factors or don't really want to talk about things they did 20 or 30 years ago because they don't really view it as part of their personality. This is why both the CDC and the U.S. Preventive Task Force recommended abandoning risk factor-based screening as our primary mode and replacing it with birth cohort screening. This recognized that 75% of patients with Hep C were born between 1945 and 1965. So a single antibody test in that group would obviously identify 75% of patients. And then we could augment it with risk factor-based screening, particularly in young people who might have current risk factors, IV drug use, etc. The problem isn't that that wouldn't work, it's that it hasn't been implemented. Despite the recommendations, despite it having a clinical grade of B, which means it has to be covered by Medicare, doctors don't do it because it isn't part of their routine. So I fear that until it becomes part of meaningful use, which makes doctors do it, or until patients start asking, it really won't happen. Though we do see once a physician gets it into their standard screening algorithm, then it happens. The more technology helps us, provides alerts, the way it does for meaningful use, the quicker we'll get all of these patients identified and then hopefully linked to care and treatment. Most of the distant risk factors have to do with drug use. I certainly have patients who used drugs when they were in college, whether that's intranasal cocaine or experimentation with intravenous drugs, and now work on Wall Street or as lawyers or doctors and wouldn't think of themselves as drug users because it was in their past, wouldn't put it on their health survey, and as a result, don't get identified. They also find it implausible that something that they did 30 to 40 years ago could be dormant for this period of time, not produce any symptoms, and often not be detected by their physician, who they've often been seeing every year, getting blood tests, their cholesterol checked. So they find it impossible to think that that would be their risk factor. For other diseases like HIV, you don't have a risk factor from 30 years ago and not be detected for all these years. Most risk factors for viral diseases are current. And so I think it's the distance of the risk factor and the fact that in very abbreviated medical appointments, we don't have enough time to really delve into our patients' histories the way we did when each patient was seen for an hour. The birth cohort screening was recommended because it was recognized that the people born between 1945 and 1965, the so-called baby boomers, they were in their 20s and 30s during the 70s, late 60s, and many of them may have used drugs during that time. That's when the infection occurred. They've now aged. They're now ages 45 to 65. They also are the people who were most likely to get a blood transfusion prior to 1991 when we started screening the blood supply. And so if you just looked epidemiologically, looking at our data from national cohorts like NHANES, and you identify the people who test positive, that's where they are. Some of it has to do with risk factors and time, and just some of it has to do with, like all diseases, they have their peaks and valleys, and there are people who were born prior to 1945 who have Hep C, a very small number, and people born after 1965. But this would identify the majority. Now, obviously, we have a rise in IV drug use now in America, and I think we're going to see a rise in younger individuals with Hep C, which means that we cannot let birth cohort screening replace risk factor-based screening, particularly in younger people. One would hope that with risk factor-based screening being replaced by birth cohort screening, that we would still see fewer and fewer new diagnoses. But given that this vast number of patients still have not been diagnosed, we are still seeing new diagnoses all the time. So we are seeing new diagnoses, and this is why it is of critical importance that we have adoption of the baby boomer or age cohort screening as soon as possible and as broadly as possible by primary care physicians.